sharp stabbing pains on my left-hand side.
The sharp pains and this dull, heavy ache.
I was tried on morphine, endone, codeine.
Crying, I was screaming, I was like yelling.
Severe shooting pain in my leg.
Sometimes I just feel, I should just get up, jump off the balcony or something.
I'm on the ground screaming or crying, or I can't help out of the shower by myself.
The pain is so intense that you'll fall unconscious.
My partner and I had sex and I was up until about 3 a.m. So I can't even describe the pain.
I was on ketamine infusions for weeks at a time.
And they had to put me in a wheelchair because I just couldn't move.
I had to get put into isolation because I was so crazy.
I wouldn't be able to move my legs because they'd go all jello-y.
It got to the point where I was begging doctors for a hysterectomy. I was done with the pain.
It's frustrating to see your child on the floor in that state and you're giving them the Ponstan tablets or
Panadol
osteo. Yeah, Panadine Fort. I've given the child Panadine Fort, which is not great for bowels, but it takes the pain. And if she can get a few hours sleep, we're both happy with that. I'm just at my wit's end. I just don't know what else to do.
I wanted to start by explaining a few things about that bigger picture that is endometriosis. I finished my gynae training in 1996, which is quite a long time ago. It was those days when laparoscopy was really getting going and so much was changing in techniques and new things all the time. And we had that probably quite quaint belief that if we could just get the surgery right, we could fix pain. And I sort of started in practice just wanting to be the best surgeon I possibly could. And over the years of looking after many women with endometriosis and pain, I realised that sometimes, the surgery could fix pain, but unfortunately sometimes it didn't. And actually, I got quite good at doing surgery, but not everybody got well, and not everybody's pain went away. And that's when I started thinking about pelvic pain and endometriosis much more broadly. And I would encourage you today to think about your own situation, not just, do I have lesions in my pelvis that need cutting out? But let's look at the whole picture. Let's look at everything it means to be a woman with endometriosis and pain. So, starting here with these, I think it's worthwhile going back to the beginning for everybody and thinking, how is it that a child who is so well turns into a woman with pain? Does it matter if you're born a girl or a boy? So this is a study that I think is so valuable. It actually looks at children with a long-term pain condition. This isn't all pelvic pain, it's not all periods or endometriosis, but I think it's good to look at what happens to the children. So the red bars are girls and the blue bars are boys, and if you look at them in their age groups, the young ones, very few young children have a persistent pain condition. But once those hormones start going up, once they get near puberty, the girls rapidly outpace the boys in the number that have a long-term pain condition. So by the time they get to between 16 and 18 years, the girls are about 5 times more likely to have a significant pain condition. And in that group, it wasn't all period pain, but a lot of it was abdominal pain, headaches, and some limb pain from accidents and things. But the girls not only were more likely to have a pain condition, but they were more likely to have more than one pain condition, and their pain intensity was higher than the boys. So we are, as women, predisposed more to have pain conditions than the men. It's just dreadfully unfair. So does it get better? As they grow older and things go on, does it actually get better for women? Well, unfortunately, no. This is a list, you don't have to read them all, of pain conditions generally that are more common in women compared to pain conditions that are more common in men. I think you can see that the women have more trouble, and also that the ones included, like things like fibromyalgia, a painful bladder, all those things, are more common in women. So where does endometriosis fit in? Because that's what you came to hear about. So this, in case you haven't actually looked at many of these pictures before, is what a woman's pelvis looks like from the inside. And the big pink thing in the middle is the uterus, and the white things on the side are the ovaries, and outside there's the fallopian tubes, and the area in the middle between those two strappy areas, maybe I can show it, this area here, that's that place you've probably heard of called the pouch of Douglas. And a strange name. For anyone that doesn't know, James Douglas was physician to the Queen in England in about the 1700s. He was an anatomist who described the lowest point in the pelvis. So there you go. Now, if we look now, I've got a video showing some different features of endometriosis in the pelvis. So I think now, yes, there we go. Just showing you all the different features. So this is looking around a pelvis. And this is pouch of Douglas, and if you look in here, I'm hoping you can see, there's lesions there, but they're lots of different colours. So there's dark bits, light bits, but if you look here, there's little tiny clear areas, often easy to miss and hard and easy to ignore, but they are probably at least as painful as any of the dark lesions. And it's been shown that the clear or reddish lesions, there's some under the ovary on that side, are if anything more painful than the black ones. So looks aren't everything. If we look on this side, you see there's some humped up areas there, a bit scarred, different colours, white bits, dark bits, lots of different features. And this is all endometriosis on the left side of the pelvis. Now, none of this would show on an ultrasound scan. You've probably had many scans that didn't show a lot. A few of you might have had cysts that showed. This is another area on the side of endometriosis with inflammation around it, and that's a beautiful normal appendix. So, well, I like them anyway. So that's it. Now, this is a picture showing what some of you may have had, a chocolate cyst, and that is something that will show on an ultrasound. So we see here, we've got the round cystic thing here, and that's the white ovary. Don't worry about the bit of blood there. Fallopian tube, white ovary, and the chocolate cyst there. And that will show on a scan. But over here, we've got, when you open it, out comes the chocolate stuff that looks just like ice magic. And which my son loves on his ice cream. And so that's why they're called chocolate cysts. But remember that these are only a small percentage of women with endometriosis. Now, we've got two pictures here. So first of all, we've got the one on the left, and she's got, that's her uterus, ovary, tube, bowel going down here, and there's a bit of grey, white tissue here. Well, that's endometriosis, so's the bit over here. It's nothing dreadful. Most of her pelvis looks quite good, but on the right side, we have a woman with severe endometriosis. That's the uterus. Sorry, I'll stand around here so I can hear. The uterus, a great big ovary with 2 endometriotic cysts in it. Another great big ovary with endometriotic cysts, and the bowel completely stuck to everything. But who's got more pain? You can't tell. There's no reliable correlation at all between the amount of endometriosis and the amount of pain. The woman on the left came to me with dreadful pain. The woman on the right, with all the severe disease, came along saying, I've never really had pain. She was only coming because she wasn't getting pregnant. So I think it's really important that we actually lose the concept that the amount of endometriosis fits with the amount of pain. That's been holding things back for a long time. And I call them common pain misconceptions. And the first one is that if there's pain, there should be something to see at a laparoscopy. Well, why? There's lots of pains you can't see. Sometimes you can see things at a laparoscopy, and sometimes you can't. Remember, no good correlation at all between the amount of pain and how much endometriosis there is on a scan. Fertility, yes, but not with pain. The second misconception is that if you do a laparoscopy and find something, then that was the cause of the pain. Maybe, maybe not. You have to actually think, what sort of pain was it? And is it the sort of pain that does what we found fit with what she actually came with. Remember, there are many pains you can't see. There's much more to being a woman with endometriosis than just what you see in a laparoscopy, which is the things called lesions, much more than just lesions. You are all much more than just lesions. This is a picture that you might actually identify with. Maybe this was you. Maybe you were 20 and you'd had painful periods since you were 12. But you also now have irritable bowel, food intolerance, headaches, overactive bladder, bloating. You might have pain on movement, an achy pain, stabbing pains, painful sex. But there's all the rest of it as well. What about the fatigue, the nausea, the anxiety, the sweaty, the dizzy, the low mood, the poor sleep? I think this is the big picture of endometriosis. So when you're thinking about the whole big picture, it's worthwhile comparing this sort of pain to other persistent pains that people might get. So for almost all long-term pains, the pain starts somewhere. Then you often find that nearby muscles get tight and tender and painful. If the pain's been there a long time, you get changes to nerve pathways, the way the pain messages get sent and received by our spinal cord and the brain. And then there's all those long-term life impacts of being someone with a long-term pain condition. So for example, if you are somebody, maybe you're a middle-aged man who's got a back injury, a long-term back injury. Probably not most of this audience, but maybe you know people. And yes, there could have been a problem with the back at the beginning, but often people will describe that the back muscle spasms that go with it are their worst pain. They're easily diagnosed because you can feel those muscles and people recognise it easily. And anybody who's had pain of any kind for more than 3 to 6 months on most days has changes in the nerve pathways. That's just the way our brain and spinal cord adapt. And then there'll be the long-term impact of that person with back pain on their employment, their relationships, their wellness and things. Just the same, if you've got long-term migraine headaches, you'll get tension in your neck and a whole bunch of other troubles with it. So there are similarities with the pain in the pelvis to some other types of pain. So what makes pelvic pain like other pains? Well, the pain started somewhere. The periods and endometriosis are a potent trigger for all of this. Nearby muscles get tight and tender and painful, and that can be the pelvic floor, the one that goes across the bottom of the pelvis, or a muscle you might not have heard of called obturator internus, which is on the inside of the hips. Now, nerve pathways change, and that's when all the fatigue and the nausea and the anxiety get going. And then there's all those lifetime impacts that you know all about. The withdrawal, the financial, the educational, the social and the relationship implications. So, what makes it different from other pains? I think that the fact of a pain that starts so young in life is a big problem. The endometriosis and the periods are this early driver of a pain process. There's estrogen as a nerve sensitizer of nerve pathways, and that cycle with every month there's a new stimulus to pain. And there's all those problems that young women can have. We're all awkward in our teenage years, but who wants to be awkward in teenage and have an invisible, potentially embarrassing problem that you don't want to talk to other people about? So, getting better. First thing is to stop the problem that started it in the first place. And for a lot of people here, that might be endometriosis. And this is where a laparoscopy can be really useful to try and excise and remove those areas of endometriosis. It's just part of the story, it's not the whole thing. But that can actually be useful. There's always important to remember that period pain isn't just the lesions, it's the uterus itself. And that one, you need to have a plan to reduce bleeding, because you don't want everything to be stirred up every month with a new period and a new aggravation. And also those hormonal cycles, those estrogen surges that happen, that are probably contributing right from the beginning, even for some people a bit before their period started, with that increased risk of pain conditions. So this is what you'd do optimally. You'd actually remove the endometriosis, cut out as many periods as you can, and preferably cut down those hormonal estrogen cycles. As you know, it's not always so easy, but that's what you'd aim to do. So you aim for as few periods as you can get away with for young ones until you want to have a baby, because that will reduce the chance that everything gets sensitised and everything gets aggravated. And so that you can understand the approach to this, I've got a picture here of a uterus, and endometrium is the lining of the uterus, the bit that grows each month and bleeds away with a period. And just generally, estrogens would tend to make that lining thicker, periods more painful, periods heavier. Progestogen hormones tend to make that lining thinner, periods lighter, periods less painful. So, as a general rule, it's how much progestogen does one need to actually reduce the periods and start settling down the initial aggravator. So, how much progestogen do you need to manage your periods? So this is why the first thing that might be offered to a young woman is a contraceptive pill. And it's not enough for everybody, but it's a start, and for some people it's a great start. You want one that's balanced more towards the progestogens than the estrogens, and the ones that I would tend to prefer, Levlen's the one that half Australia takes. It's a standard pill. It's not the best for period pain, but it's a standard one. Noramin or Noramin 1 have more progestogen in them, and they're all PBS ones though, so they're cheap and easy for people to take. Yaz is more expensive, but it's a lower estrogen pill, and you can use it continuously, so it's one that it can sometimes be helpful. And one that actually isn't used very much is one called Clara. And Clara is good because it's one of the few ones that has a special estrogen in it that's good for people that get moody on the pill. So if you're somebody who says, oh, I can't take the pill, it makes me crazy, the Clara has a special estrogen in it. It also has Vizan in it. So you get Vizan plus a special estrogen in a contraceptive pill. The downside is you can only have it on a monthly cycle. You can't take it continuously, but periods are often light. The downside is also that it'll cost you about $30 a month to be on, but it may be that that's valuable to you to know. Skipping periods is useful. You want as few as you can, keep things quiet. A Mirena, they don't suit everybody, but they are progestogen only, and they thin out the lining of the uterus and make it easier to take pills and things to manage the periods. Remember that you can add things together. So if the Mirena is going okay, but you've still got cycles, still got periods, you can add a pill as well. The Mirena doesn't give you much hormones to the rest of your body, so you can do two things together. And probably, if you really have found everything difficult and you can tolerate it, then a Mirena and Vizan or Primulet, which is a cheaper, more old-fashioned version of a progestogen, but still useful in some people, can potentially stop periods in a lot of people. Some of you may have been on GnRH analogues, things like Zoladex or some of those things that put you into a type of menopause. This sort of thing doesn't come with the menopause things. You might find it actually a whole lot easier to tolerate. It's a matter of getting the one that's right for you. Remember to treat any other pelvic pains that could have been aggravating the whole thing in the first place. You aren't just a uterus and you aren't just lesions. You've also got a bladder and a bowel, and you might have had bad thrush or something. All these things can start that bad process of pain. And remember to actually, if you've got bladder symptoms, they need treating. If you've got a dodgy bowel, that needs treating. If you've got recurrent thrush, there's plenty you can do for that. Now, the pelvic muscle spasm, and I think this is so important. I'm listening to those videos of those people talking about their pain, and for many of them, I'm hearing pelvic muscle spasm. I'm not hearing they've still got lesions that haven't been removed. I'm hearing pelvic muscle spasm. And this has been such a neglected area. Just as we said that with back injuries, you can have back spasms, and many people with a back injury will say, that's my worst pain. For women, the muscles are on the inside, and it's so easy to miss the contribution that the cramp in those muscles makes. And no matter how things started, the pain can be complicated by pelvic muscle spasm, almost any pain. So the pelvic floor muscles, these are the ones that go across the bottom of the pelvis. You probably know those ones, the ones you tighten up if you want to stop passing urine. So the typical symptoms that go with that type of pain are pain with sex, pain with smear tests, not liking tampons, not liking vaginal examinations, pain with movement or ache. Now the uterus or endo, they don't care what position you're in, but if you're someone who finds it hard to move, you get sudden stabbing pains that mean it's really hard to get going or get up, that's a muscle spasm pain. Difficulty emptying the bladder, well, you know, it's hard to pass urine past a contracted pelvic floor, and often pain in the lower back. So these sort of symptoms are so common, but so easily mistaken for other things. Now this one, pain from obturator internus. You've probably never heard of obturator internus. It's not one of those ones you'll see on bodybuilders or, you know, six packs and things. It's on the inside of your hips. And it's the muscle that attaches actually in one bit to the top of your leg. So if you have a cramp in obturator internus, you're going to find it really hard to move. And the classic thing that people come with, I can see them in the waiting room. They get up really slowly. They find it hard to move. They sort of walk in like this. They talk about the stabbing pains on one side that make them want to bend forward. They want to curl up in that fetal position. They find it hard to move or walk. They like their heat pack, and there'll often be that achy pain. Could be one side, could be both sides, but it's the sudden stabbing pain. And it sometimes goes down the front of the leg or into their back. You can actually palpate that muscle vaginally with a finger if you push in the right spot out the side. Bit hard to do to yourself, but you can actually find that muscle if you go to somebody who's used to examining it, and they will touch it and you will say, yes, that's my pain. And if you've had a vaginal ultrasound and you really don't like that vaginal probe pushing out the sides, this is something to think about. So how do you treat it? Well, you stop the aggravating factors. Anything that talks about core strength exercise, Pilates, building up your core, personal trainers, planking, etc., is going to aggravate that pain. You've got to keep moving. Muscles like to move. They don't like to lie in bed all day. And even when the spasms are bad, you feel like lying in bed all day, that actually can aggravate the pain. So it's good to keep moving. Exercise is really important, but it has to be away from the core. So walking, or most of the yoga poses, or some of the dancing like sort of salsa, not ballet which is rigid, but salsa-y, loose things are often good. Sometimes swimming, not thrashing up and down, but swimming to move the body normally. There's a pelvic muscle stretches that you can do at home on the Pelvic Pain Foundation website. And if you look at this website, there's a special downloadable pelvic muscle relaxation CD that has two of the physios that I work with talking people through pelvic muscle relaxation that they can do at home themselves. Pelvic physio is so important, and I'm so pleased that Sharon Jarvis is going to be speaking today about it. So important. But the knowledge on physios in this area is quite hard to find. So you will need to be careful about which physios you go to. If they talk about building up your pelvic floor, or the things hurt you, or you're not talking, you know, they're not down training, maybe you need to look somewhere else. For the most severe ones, we use Botox in the muscles. And you might think, well, there's not a lot of cosmetic benefit from this. But for pain, you know, children with cerebral palsy have Botox in their muscles so they won't spasm. And you can give someone a bit of a break from the pain and let things settle down a little bit. To give them a chance to put in place other strategies with the Botox. I have found it fabulous in our patients with the most severe stabbing pains. It's not always available, and it's early days. We'll have a petition somewhere for anyone to sign who's actually interested in trying to get more attention for this treatment. Now, the nerve pathways. A lot of people don't want to engage with this. They think, she thinks I'm crazy, or of course I know I've got things in my pelvis. But anyone with any pain for more than 3 to 6 months has changes in nerve pathways. It's just the way it is, no matter what the pain they have. You'll recognise this when the pain's bad. You're just really sensitive in the pelvis. You don't like anyone touching you. You don't like tight clothes. Everything's just sensitive. And you'll also notice it because this is, once the nerve pathways get sensitised, this is when you start to feel bad. The nausea, the fatigue, the poor sleep, the anxiety, the low mood, the sweaty, dizzy, those sorts of things. And if you have a burning pain, that's a nerve pathway pain. Exercise is absolutely essential. It doesn't have to be flat out, but you need to keep moving. Every day lying on the couch is a day going backwards. Regular sleep, tricky in this area, but really important to actually have a regular lifestyle. This is where some of the medications that you may or may not have been offered can have a really good role. They don't suit everybody, and there's information on how to use all of them on the Pelvic Pain Foundation website. Amitriptyline, that you may or may not have been offered, in small doses is fabulous for a lot of things. It helps the overactive bladder, the pain pathways, the headaches, the sleep, and it can reduce irritable bowel. And this medication, to explain it, used to be used in the old days in big doses to treat depression. No one uses it for depression, and the doses we use wouldn't treat depression anyway, but it's used for a lot of things for pain. I think half the people who go on it find it really helpful and half don't. They can think of other things. Duloxetine is a medication that is used for anxiety and depression, but unlike most of those things that you may or may not have tried, this one also helps pain pathways. So most of the things called SSRIs won't help pain pathways, but this one can, as well as helping anxiety and low mood. Pregabalin or gabapentin have been used, and I think for some people they're useful. I would normally go through in the top two first. This is where it's fabulous to go and see a pain specialist, and this is someone who can complement the care you get elsewhere. They can look at the overall pain picture. If you do, I would be very cautious, really good to stay away from regular opioids or narcotics. Unfortunately, they are just a trap. It's very hard because often people don't know what to offer you when you have bad pain. And for short-term use, a few days after an operation or occasionally, sure. But regular ones sensitise the nerve pathways and they actually make the pain long-term worse. So if you possibly can, regular narcotics are not good. Reducing the life impact, it's really important to keep active with things you enjoy or are motivated that you believe in, things that matter to you that you'll still do even if you're not feeling quite on top of everything. So keeping active is good. The sort of person who says, look, I'm going to stop work to get better, unfortunately then the brain just has unfettered ability to have the pain take over the whole thing. And while overwork is not good, I think underwork, under being busy is not advantageous either. Reducing the fear and anxiety, the more you learn and coming to things like today, will actually allow you to feel more confident and less concerned and less worried and scared about the pain, and with better management strategies. A pain psychologist, if you can find one, they're not so many, is fabulous. Exercise is wonderful, and you've probably all learnt that you have to pace your activity, not too much one day or you fall in a heap a bit the next. But won't surgery alone be enough? Well, I've got another little video here. This little one was 15 and she's got widespread endometriosis. So all over here is sort of clear bits, little blood vessels, black bits, white bits, clear little vascular areas. Ovaries are beautiful, but all of this is all abnormal. All of this is abnormal, even though she's only 15. And across here, across the pouch of Douglas, all of this is abnormal. That's rectum there, but all of this is abnormal. And on the other side here, black bits, white bits, no good. And so I've taken off all of the peritoneum. In a minute you'll see all of it has been taken off, all the abnormal tissue, and it will grow over within a couple of weeks. But we've completely removed every bit of endometriosis. The ovaries, there we go, the ovaries are loosely tied up with a very dissolvable stitch to keep them away while it heals. That will break and they'll return to normal position. But everything has been removed, all that abnormal tissue. All better now? Is she fixed? No. She's got much more than just endo. We need to minimise her periods. So she had a Mirena and continuous pill. She's got constipation. So she's using my favourite thing for that, Normacol Plus, which is delicate and gentle for the bowels. She's got an overactive bladder, so she's on a little bit of the amitriptyline. She's got achy pain from the muscles, so we actually organised some regular exercise, the stretches and some pelvic physio down training. That doesn't have to be vaginal examinations. She's missing school, she has anxiety, and she was starting to self-harm. So we've re-engaged with school and things, and she's seeing a pain psychologist. Now I saw her after 2 years recently, and she's fabulous. But this is an ongoing thing, we will have to keep seeing her. Just keep an eye on things and keep a handle on everything. Surgery is part of it, it's just not all of it. So this is the Pelvic Pain Foundation, and there'll be there's resources on there for you and your doctor, and we are an organisation that's more to do with research and education, and we hope to provide resources for everyone out there with pelvic pain. Thank you very much.